Good morning, everyone, and those who may be, both to those present and those who may be watching virtually on YouTube. Welcome to the Health Committee for Wednesday, June 12th, 2024. It is 9:30 a.m. As we gather this morning, I wish to acknowledge on behalf of committee and our community that we meet on traditional territory of the Algonquin Nation. We thank the Algonquin people and express our respect and support for their rich history. We are extremely grateful for their many and continuing displays of friendship. We thank as well all the generations of people who have been careful stewards of this land for millennia. With that, Ms. Van Starkenburg, has the roll been called, please?
Yes, thank you, Chair, and we have quorum.
Thank you. I would invite disclosure of pecuniary interest, and if there is any, the general nature thereof, please. I see none. I would seek a motion, I think a single motion, Mr. Kelly, to approve two sets of minutes, one from the May 15th regular Health Committee and one from the May 29th special Health Committee. I would have a resolution, please. Councillor Wilmer, seconded by Councillor Grills. Any errors or omissions? I see none. All in favor? That is carried. A new feature that I think that is just debuting this week, this committee week, we have determined that committee and council may in fact approve closed minutes in an open session. However, should there be any question or comment on the closed minutes, then it would require the group to go into closed to then discuss. But in the absence of any question or comment on the closed minutes, then they are approvable, and this is much more efficient in being able to distribute to the closed minutes much closer to the closed session. I'm sure everyone in the room has had that uncomfortable position of seeing closed minutes from a meeting that was held 6 months ago and hoping that that was an accurate reflection of what the discussion was. So in this event, that will no longer be required. So there are two closed minute meetings. Just bear with me one moment as I bring them up. There were closed minutes of March 6th, 2024, and again on March 27th, 2024. I would seek now a resolution to approve those minutes. Councillor Weir, seconded by Councillor Lafreniere. I will offer any question or comment given the earlier advice. Sorry?
Sorry, Councillor Lafreniere was absent at one of the meetings I have on my note.
Okay, so I will seek an alternate seconder, please. Councillor Yan. Sorry?
Councillor Yan was also absent.
Strike two. Okay, I need to bring the heat. Councillor Nicholson, seconded by. We're good. Excellent. Once again, predicated on my earlier advice that if there is question or comment, it would require us to go into a closed session. Is there any question or comment? I see none. All in favor? That is carried. That was actually a ruse to find out who was actually here at previous meetings. In any event, thank you very much. That is our inaugural run at closed minutes. Now we move to delegations. We're very pleased to have a delegation this morning from the Ottawa Valley, Ontario Health Team. I would prevail upon Mr. Kelly to please introduce our guests this morning.
Excellent. Thank you, Chair, and good morning, Committee. It's indeed my pleasure to welcome Sabine Mersman, who is the President and CEO of Pembroke Regional Hospital, but today is also the co-chair of the Ottawa Valley, Ontario Health Team, of which we are the transfer payment agreement holder for, and several of our department heads play a key role in different committees on the OHT. And with Sabine is Jema Watt, our strategic implementation lead, and they will walk through a bit of a refresher of the OVOHT and where we're at in 2024. Thank you, Chair.
Thank you very much, and welcome, Sabine and Jema. And committee, the presentation was provided. You can watch it on the screen, as well those people that are virtually attending or watching virtually, but you also have it on your own screens. Welcome, Sabine, the floor is yours.
Thank you so much, and thank you for having us here to present at Health Committee about the Ontario Health Teams. I have to say that the entire process of Ontario Health Teams, the naming and all of that is highly confusing. So it's the second time we're here. It's still confusing to Jema and I sometimes on where we are going in the province of Ontario and what it is all about. And it's so easy to confuse Ontario Health Teams, family health teams, and all of those principles. So we're going to try to kind of demystify it a bit today, and we are happy to answer questions about it as well. No? Yes, great. So Ontario Health Teams, I think the reason why, we believe it has been around for a long time, we have been talking about it for a very long time, around 2019 when the Connected Care for Health Act came into play and the government decided, we needed to move into this direction. But then remember COVID really put a huge stop on the development of Ontario Health Teams. And when we think about the work of OHTs, I would say in the last 2 years we have really gotten legs underneath Ontario Health Teams and are moving in the right direction. But let's bring us back to what the initial principle was. And what we are trying to show you here is all of these puzzle pieces are what people in our community experience in terms of healthcare. Some of them are occasional, some of them are on a long-term basis, but some of the services are provided in their homes, some of them are provided in the community, some of them are provided in hospitals. And the system is perfectly designed to be really, really complicated because, we have designed a system where I would say even in Renfrew County, there are probably hundreds of providers that are providing pieces of those services. So the point of Ontario Health Teams was, how do we make this actually easy for people to navigate? Because we can't change the system. It would be extremely disruptive to do anything major in restructuring it. But how do we actually get people to work together to make this simple? So first of all, just a bit of an overview on how the structure works. With the dissolutions of the LHINs in 2018, Ontario has decided to restructure the way we are looking at healthcare. So Ministry of Health stayed the same. Sylvia Jones is our Minister of Health, as you well know. And then the ministry decided we are going to give oversight of all of the kind of clinical best practice areas to an organization called Ontario Health. They created the organization. The current CEO's name is Matt Anderson. And they have a whole bunch of agencies underneath them who all were standing on their own before, like Cancer Care Ontario. There's an agency called Core Health that's looking after heart issues, Health Quality Council of Ontario, the Trillium Gift of Life, who's looking after organ donation. So there are many, I think about 15 or 16 agencies. They all are under Ontario Health. And Ontario Health is divided into 4 regions, and we belong to the East region. So just imagine, before we had 14 LHINs, we thought, that was kind of a large area for the Champlain Health regions. Now we have 4 Ontario Health regions. And the person who is leading us for Ontario Health right now his name is Scott Ovenden. He's our Chief Regional Officer. He's in charge of Ontario Health East, and that's all the way from Toronto to Deep River. It's a huge, huge area, and his attention is sometimes, as you can imagine, likely centered on the GTA because he does have Toronto, and there are many issues there because so many people are living there. So then, under Ontario Health East, we have the Ontario Health in general. We have the Ontario Health Teams. There are 58 now in the province of Ontario. So I think the vision for the ministry is all the big best practices issues, let Ontario Health deal with it. But how do we deal with local health issues that are prevalent in our communities? And our application was approved in 2021, right, Jema? So not that long ago, and the ministry assigned the Ottawa Valley Ontario Health Team. We have a population of 78,000 people. What's a bit complicating, I think, especially for the county, is that Arnprior is not part of it. And simply, that was not an oversight by anybody or the government, but the way they assigned Ontario health teams, they looked at where people receive the care. Where people are, and it was powerful data that they reviewed. Where do people travel for their healthcare needs? And what they realized is Arnprior residents really tend to go towards Ottawa, Queensway Carleton Hospital, for example, and others. So they looked at the rest of the county pretty consistently. Over 80% of the healthcare services are provided within that region. So this is why we are without Arnprior. So what's the strategic focus, really, of the Ottawa Valley Ontario Health Team? Again, complex health system. I mean, even sometimes we say us in healthcare, and I'm sure Mike and Dave and others in the room, Mathieu, agree with me on that, don't even know really what all the pieces are and where to navigate to. So the big focus is here. How do we integrate care and services so it's easier for access and navigation? And there is a large belief, and we always talk about gaps in healthcare, and all of us believe that there's still gaps in healthcare. But just imagine if we actually were efficiently using all the resources that we had in place right now. Maybe the gaps wouldn't be quite as huge as we perceive them to be. So the focus really of Ontario Health Team is get all of those service providers together and figure out how can we make the system collaborating together, maybe integrating care pieces, and fix that navigation issues for people who need to access the system. And then, of course, the focus is how do we make this happen with leadership, with governance, and how do we drive system transformation? I think there's again, a big belief in Ontario that local governance is a good thing and a great thing. It can stand sometimes in the way of making integration and collaboration easy. It is not that we are proposing anything in the OHT to change that. We are strong believers in local governance. But then how do we make sure we are collectively having impacts? How do we work much closer together with that local governance to come together on an integrated system? And then, of course, engaging and supporting our diverse communities. We had Peggy Dick, who is the manager of health services at Pikwakanagan, the other day at our board meeting. And she was saying, just imagine if everyone would like to have somebody from Pikwakanagan at their own board meetings or committees. I would have to divide myself into hundreds of pieces and go to millions of meetings. So we are trying to find better ways and systems on how to make sure we engage our diverse communities, but we don't pull all of the resources, and then they don't have time actually to do what they're supposed to do on their with their patients. So the priority focus for the Upper Ottawa Valley Ontario Health Team, and again, I often say we all believe we are extremely unique in Ontario. How often do you say this? Our community is unique and we need different services. But when you look at the priority focus that we have and the priority focuses that others have, I would say they're almost 100% aligned. So in Ontario, we have a huge problem with access to primary care. Is it a little bit worse in our Upper Ottawa Valley OHT? Yes, it is. We have a significant percentage of unattached patients, but again, it's the same really across Ontario. Aging in place is a huge focus. We know that the preference for our seniors is to stay in their own home, in their own communities. How do we support this better moving forward? And then, as you all know, mental health and substance use issues are a significant problem in Ontario, significant problem in Renfrew County and for the Upper Ottawa Valley OHT. So those are our three priority areas. And here's a little bit of what we actually have been doing. And this is one of the reasons why we come out to see you, because I've heard sometimes people say, I don't know. I don't really see what the OHT is doing, but maybe some of the things are not a little bit more hidden away. We have done an incredible job with our primary care providers to get preventative cancer screening rates up in unattached patient populations. And they have been working on that for about 2 years, and it is extremely wonderful to see the data, and we are actually a real lead in Ontario on having made progress there. Of course, the paramedics are a huge part of this, because through RCV TAC, initially, we actually moved to an integrated virtual care model across the OHT, and that is now supporting 3 family health teams, Petawawa, West Champlain, and Deep River, North Renfrew, so that's great. We put in a joint proposal last year on having a rural mobile clinic for substance use. I'm not sure that you know this, but our Ottawa Valley Ontario Health team, our subcommittee on mental health and substance use, got together with some of you and many participants to look at funding from the federal government in putting a proposal in to actually have a mobile unit. We are supposed to hear in the month of June. We're in the middle of it now, so let's hope it gets funded. And then we're going to have some discussions on MESA and this proposal. How do we integrate them? How do we align them? Is there a need for the county to continue to fund MESA if we get enough money for the mobile clinic? So more to come on this. And then we just secured funding for a fall pathway. And why is that so important is our hip fracture numbers in Renfrew County are climbing steady. And in some ways, that's a good thing, because seniors are staying mobile and they're doing more things. But on the other hand, this also leads to more serious trauma and injuries. And so how do we make sure that people are in getting exercises and screened early to see if they are at risk for falls, and then we can do something about it. On access, we have greatly expanded online appointment booking for primary care, and that's just a fantastic, I personally have access to it, which is incredible, and I can book my appointment at midnight if I wish to do that, and no longer have to wait for opening hours to call somebody. We established pathways for mental health services for children and youth out of the emergency departments. That was a protocol that we had in place only in Pembroke. We have now expanded it through the county. And then, of course, on the navigation side, we're really trying to streamline people to 211 and 811. And having one way for people to access information on services that are available and be navigated through those services. We did a lot of work on anti-stigma training for health service professionals, and that went through all of the service agencies in the Ottawa Valley. And we're doing a big response on equity, diversity, and anti-racism. So all of our organizations in their accountability agreements, we now have to do something about equity, diversity, and inclusion protocols. And we were given a long list of, these are all the available resources. And what the Ottawa Valley did is they distilled it down, and they're saying, here's a handful of things that we should all be looking to implementing this year, and then maybe next year we'll jump on some others. So this is very helpful for all of us. And there is work done on closing the health human resource gap and what the opportunities are. Then the work for this year that we're currently in. We actually, one thing I think that Jim and I are very proud of is we have decided to jump on a collaborative primary care recruitment strategy. I want to plead with you. Let's really work on those things collaboratively and not become competitive, particularly when it comes to primary care recruitment. We are a small area, 78,000 people. That's considered really small in Ontario in terms of health teams. Any physician in any one of our regions in the county is a great addition to the physician force right now. So let's try to prevent at every step of the way that we become competitive between towns and municipalities and cities in who gets that physician to come. Really, right now, we have such a huge demand that really doesn't matter where they go. But what's really important for us is that we show a collaborative force that is coming together, because those physicians, that's what they want to see. People that work really well together and that, that are coming together for the greater good. So we have developed a collaborative recruitment strategy, and we're just in the process of hiring a recruiter and coming up with other strategies that will help us on this front. Again, we're going to continue on preventative cancer screening. We have just created a really great structure to look at the substance use crisis and homelessness crisis in the county. And this is the Renfrew County Drug Strategy. It's led by Dr. Jason Morgenstern and Jema Watt from the OHT. And we're building 4 working groups. One of them is already the MESA table that has come together. They will be the treatment working group. We have a prevention group that is already in place, and we're building a community safety group as well under that portfolio. We are also working on specialized geriatric programs, having a coordinated and collaborative approach to that. The family physicians, one thing that we can do much, much more for them is to make it easy for them to make referrals for their patients, and for them not to have to figure out which geriatric service, which mental health service is actually the best for the patient in front of me. But there's one number to call, one referral to send, and then there are other people who are actually experts in the field who will say, you know what, for Sabina, this avenue is the best avenue, and I'm going to send her referral there. That is what primary care, that's what their life is, that's what's going to make their life a little bit easier. Expanding navigation, we already talked about that from last year. And one big next piece is planning for home care, and I'm going to talk a little bit more about that in a second. Anyway, the community needs assessment to support health human resources, looking at French language services, and we are building an Indigenous health circle that's going to be a one voice for urban Indigenous, Métis, Inuit, and our First Nations folks. So what's next? What does the ministry want next? One thing they have been doing is they have said, we are in with OHTs. We're all in. We are going to give you funding for 3 years at $750,000 a year. That is money that cannot go to patients or patient services. It's money to organize services, to coordinate, to collaborate, to bring people together. They have developed a bit of a roadmap. They do want more standardization. They're saying we cannot have 58 OHTs do completely different things in Ontario. This would lead to further chaos. So we need a bit of a standardized roadmap. So designation, what the ministry calls maturity, that's what they're hoping for us, to become more mature and then demonstrate that we're actually ready for designation. And what does that mean? They actually put a list of things into place. I don't have them on my slide, that say there are core structural components that we need to demonstrate that we can do well before they're going to come along and say, you are designated as an OHT and we're going to give you more funding, more support, and you are going to go ahead. But one thing is in our own ability to change is the ministry really wants to see us working collaboratively together, coming up with great programs, not competing with each other, but really bringing services together under one umbrella. That's what they want to see going forward. They also want to see a really solid plan for home care. If we are going to give you the delivery of home care, if we make this the responsibility of the Ottawa Valley OHT, how are you going to go ahead and do that? They want to see a really great plan in place on how we're going to move forward with that. And then what does maturity actually mean? So at the far level of maturity, what the ministry right now is saying they want to see one funding envelope for the Ottawa Valley Ontario Health Team, for all Ontario Health Teams, that will fund all social and health services, that will be governed by one board. We're still going to have our local boards govern each organization, but one board of the Ottawa Valley Ontario Health Team will receive one funding envelope, and we'll divvy that money out for the best services to patients and families. That is the long-term vision. There's very little on the how this is going to work, and all of us are having a million questions, and I'm sure you have a million questions too on how this is going to work. But they have chosen 12 OHTs that are going to walk the path ahead of us, and we're going to see how they are developing and how they are moving into that direction. I do want to say, as much as we are all a bit, I would say, frightened with some of these words, integrated funding envelope, a new governance structure, one thing that we have seen during COVID, there was a real silver lining, is we were able to move people from organization to organization easily where the need was. And that was such a positive thing. I remember all of us working collaboratively to say, how do we do this best? We want to avoid people dying. We want to avoid people getting sick with COVID. We want to deliver vaccination as quickly as possible. And we came together and we all had one vision and we really got this done. So how do we get back to some of those principles and really coming together, working collectively and getting it done faster and better, as I might say. So I'm going to stop here, and Jema and I have a couple more minutes, I think, to answer some questions.
Thank you very much. A lot of information in a very abbreviated time frame, Savita, so thank you very much. I will open the floor to questions or comments. Councillor Lafreniere, please.
Thank you for that presentation. You did clear up some questions I probably would have had, so thank you very much. Just one question. In regards to the mobile clinic that you've applied for funding, that you're waiting to hear on substance abuse, how does this differ or enhance the MESA program that's in place? Like, what's the difference? Or is it similar, or is it an enhancement, or if you could answer that?
Just before I invite our guests to answer, this is the SUAP program that actually has been discussed from the time that we began before MESA was MESA, when we were brainstorming what can we do to approach this. And ultimately, if memory serves, I think this is a $2 million grant that the federal government is making available, and that was seen as a potential source of funding that would enable MESA and continue it. In that interim period before SUAP was actually announced, the successful applicants, then we have funded it through piecemeal, I guess, various reserve accounts and other accounts, part of which are Ms. Patrick's directorship. But please invite Sabina to expand on that.
I think, Councillor Donny, you answered it perfectly. Thank you.
Thank you very much.
Sometimes I like the limelight too, you know.
This is perfect.
Further questions or comments? I'm intrigued at your comments, Sabina, that sometimes this can be challenging or frightening. I think that from the inception of Ontario health teams on the then new government taking the reins of power in Ontario, it was often we would hear the term low rules environment. And I think the low rules environment was both a threat and an opportunity. It was the two sides of the same coin. And I think that it has allowed us, even though there is an expectation of standardization across the province, it has allowed us to recognize local issues, local pressures, challenges, and imperatives in responding to this. So I think that low rules environment does continue, even as you were discussing what is maturity. I don't know if we have a full definition of what that means. However, I am intrigued because certainly at the inception of the Ontario health teams, there was discussion that these would become essentially, and this is my own definition, localized LHINs, where the LHIN was right Eastern Ontario, and even though we are part of Ontario Health East, which goes, I think, right to Durham, Ultimately, this is going to be a self-contained local unit wherein not just the services, but the funding envelope shall be administered locally. And that was certainly part of the rollout of the Ontario Health Team concept. That ultimately was what impelled the County of Renfrew to become engaged. Repeat for those who may not know. So through long-term care and the paramedic service, I think the county, at that time in 2018, 2019, I think that the budget at the County of Renfrew was $50 million, surpassed only by Pembroke Regional Hospital in the delivery of health services in the County of Renfrew. So it was integral for the county to take a role in this. And similar to the challenge that Sabina has mentioned with respect to a latent competitive nature that still exists in health services. The county is a pan-county. Everyone sitting in this room, we have Councillor Grills from the north, we have Councillor Weir from the south, we have Councillor Wilmer from the west, along with Councillor Yon. Pembroke sitting in here. There is that pan-county of Renfrew, and there is an expectation and a demand and obligation that we see this in that larger regional perspective. So I think that it's vital to the success of the Ontario Health Team that we continue to have that, and we're most pleased right now to be essentially the holder of the funds as we are working towards that maturation of the Ottawa Valley Ontario Health Team. Starting with, I went actually as you were speaking, that's why I couldn't find it. It was formerly known as the very clinical and somewhat ominous Network 24. I think that was the villain in a James Bond movie.
Well, we were still network building, I would say, and okay. So actually the ministry said you're going to be Network 24 until you figure out what you want to be called.
Okay, and that does sound very provincial. In any event, thank you so much. I don't really have any questions or comments. I'm very pleased to see, oh, sorry, we do have Councillor Nicholson. I beg your pardon.
Thanks, Chair. I had two questions, if I could. The first one is just, you triggered me with the maturity and the one-stop shop for the funding to come to the area and agencies. Is public health considered one of the health services? Is it going to be under the future OVOHT?
Yes, a great question, actually. So it's not in I would say, the priority services. Hospitals, long-term care, home and community care, primary care, I think, are the four. But it's one of the EMS, public health, all of those are suggested as being part of it. And actually, we just added Dr. Jason Morgenstern to our steering committee, which is wonderful. So, yes.
Oh, that's perfect. And it speaks to that collaboration with the drug strategy.
That's right.
Between Jama and
Jason.
Perfect. The next one is if I could, Chair, like my personal bugbear, which is senior support, and home care is listed on the slide.
Yes.
Now I have just a few things I want to dig in, and Jama knows because I always bring this up. But home support is vital in our communities, but it isn't addressed on your slide.
Right.
So if you could speak to the difference between home support versus home care, and how the OHT might become involved in that. And then I have one follow-up to that.
For sure. First of all, I want to say, so home and community care, that's right now known as home and community care, that used to be home care. Actually, the administration was situated in this building when I worked for that organization. Then when CCAC, then home and community care services, is becoming Ontario Health at Home. So another Ontario Health at Home vocabulary that we need to use and not confuse. So they're going to move July 1st, Jama? Yeah, like really shortly. Will all be employees under one umbrella. And then the vision is for them to stay to stay one large agency. Everyone in Ontario will be employed by that same agency. But locally, the OHTs will be directing the care that they provide. And to your point, Neil, I think the real important thing, whether it's with seniors or in mental health and substance use, is because we have so many service providers who are providing pieces of the puzzle, people who are paid and not paid, people who provide only one particular service, some people who provide a multitude of services. This is why it's so essential to do this collaboratively under one umbrella, to say we don't want to step on each other's toes. We don't want to have a community paramedic, a volunteer, and a home and community care provider driving into the same home for the same purpose, right? So how do we really ensure that we use the services that we have, navigate them appropriately to the senior's home, and ensure that they can stay there? And I think we have an aging in home project team. Is it called project team, Jema? Mm-hmm. Yes. Who that's their responsibility to really look at what does that look like, and where can we make changes. And why it's so important for us to come to you with this information, we are also planning actually a session of all board representatives in the Ottawa Valley OHT to come together in the fall, because in the absence of information, I think we all want to try to fix a system and then come up with a further fragmented system, because we're all like, I see this big gap in my community here. And unless you have somewhere to go or somebody to ask to say, is this service already available? Then you're going to say, my community needs it, and I'm going to develop it. And so how do we stop that from happening and really bring people together who are the experts in the field, already knowing what programs are in place and coming together? I think the huge gaps, that's my own opinion though, now not talking as the co-chair of the OHT, but we have a huge human resource gap right now. And I think most of us are suffering with that, and particularly our home care providers. But Jema, is there anything else you wanted to? That's good.
And thank you for opening that door also on the health human resources. I know that it is estimated just within the health sector, but exclusively within long-term care, the number that is projected and has been projected for quite some time of the PSW gap, 51,000 across the province. That's Ontario alone, within long-term care alone. So I cannot imagine, I don't know if you're privy to what numbers are that may exist across the province, but the challenge that we are confronted with the health human resources in particular is inordinately concerning for me. With respect to the overall comment, I just wanted to add some comments because I've been sitting in this chair for a few years now. And when the LHINs were still stood up, and what I would suggest even backing up further from that, so the foundation, the predication for the Connected Care Act for Ontario health teams was the Ending Hallway Health, which was perhaps the single largest slogan of the now government, then brand new government, in 2018. And vividly recall seeing the key performance indicators out of the Champlain LHIN. We were part of the Champlain LHIN. Home care, supports at home, was the biggest challenge of how long people were waiting, well beyond what they were supposed to be, on what the benchmarks were. They were not getting the services at home. And all of these things begin to compound, as Sabina has said. People's preference, who we are serving in this sector, their preference is to remain at home. But if we cannot provide those services, then it cascades through the entire system and ultimately has left the challenge that is confronting us now. So I think that Councillor Nicholson's comments are well earned, that theoretically we have the model that provides for these supports at home, but in practice it has been an enormous challenge to try and meet that target.
And I mean, I worked for home and community care from 1988 to 1999, and I would say even then it was a challenge, right? We have not been able to fix it. And I used to travel the county as an occupational therapist, and you all know how vast our county is. So we have an added challenge, right? We can't be seeing, a nurse can't be seeing 10 or 15 people in one apartment building. For her day, it's likely a 4 or 5 patient visit. So it's not making things easy in rural geographies, that's for sure. But I think right now, the will is there. I think we have the structures in place to make this a much more collaborative in the next few years. Now we have to overcome that HHR challenge.
Thank you. And you did have a follow-up, Councillor Nicholson.
Thank you for your patience. Yes, and I think it's a priority not only for the OHT but even for local government. The support for our residents in each one of our communities that want to age in place. We want to be active participants in supporting this being achieved. So I'm glad that we could talk about it today. So the next one, the follow-up project, this discussion has to do with those, and this comes from our Director of Long-Term Care and me bothering him with questions about numbers on the wait list. And those that are, and I can't remember the definition of the critical 60 people in Renfrew County that are waiting for long-term care but can't get it. What we know is that a portion of them are being serviced by our community paramedics. We know a portion of them are ALC occupying hospital beds in one of our hospitals. There's a gap there of X number of seniors in this red grouping. I don't know what that number would be, somewhere in the 20, that we're not sure who's supporting them or how they're getting supported. I'm curious to hear from an OHT perspective, what are your insights and how do we solve that going forward?
Right, excellent question. I mean, you know that we have a few long-term care beds coming online in the next few years, and both in Deep River and at Marion Hill. But what's really interesting on this point is when we did long-term care planning, and Mike would know this much better than I do. The anticipation or the thought was baby boomers, which, I think I'm probably part of that group. We're only going to have a finite length of time to live. And, once that baby boomers are gone, we actually won't need all of those long-term care beds. That was always kind of in the backs of our mind. While that data is shifting drastically, and there will be data coming out, I think it'll be available within the next 2 or 3 weeks, was modeling that was done in the UK on where is this actually true? And it's not true. What the modeling is showing is that we are living so much longer, but we are not living well necessarily. And that's also frightening. So the length of time that the baby boomers are predicted to live with disease or with illness is significant. And the burden on the healthcare system, before we thought it was going to go like this, and right now it's showing it's going this way. So to your point, Neil, we need to do more. Of course, it also really behooves us to do more on the preventative side, because the reason why we're living so much longer with disease is because of all the chronic diseases catching up with people. So we can't lose the prevention side just looking at the end result. But you're absolutely right. I think the planning, we need to go back to the planning table to say, what are we doing? How do we meet that disease burden that's about to get worse and worse and worse when we already can't meet it now? And I think that is absolutely the work of the OHT. Mm-hmm.
Thank you. Final opportunity. Any further questions? I see none. So once again, thank you so very much, Sabina, this morning, and Gemma, for coming here. And I think that this probably is integral to moving towards maturation is the communication aspect, the openness. Couldn't agree more that ultimately the healthcare system needs to be focused on the users of the system rather than the system itself. And I think that this is hopefully finally each one of from the district health councils through the LHINs, now the Ontario health teams, you had identified the scratching out of the name on the door of home and community care, how many different names it's had, but you showed up to the same office. I think that there is that goodwill effort to really begin to focus on meeting the needs of our community, and I think that this is the means through which we're going to get there. So thank you incredibly for being here today.
Thank you so much.
With that, Mr. Kelly, if you would be so kind as to take us through the administration report, please.
Thank you, Chair. Before I begin my administration report, I do want to just take a bit of latitude, if you don't mind, Chair, and we spoke about this. Chief Mike Nolan is unable to be here today. He's in business in Toronto. Deputy Chief Curtis Farrell is with us today, but this is his last time as deputy chief here today. Mr. Farrell has decided to go back to college. So it will be departing his role as deputy chief. I would like to thank him for his time served. I understand Curtis is going to stick around for a little bit and be a part-time paramedic once in a while, part-time commander. So thank you very much for your service, sir. Thank you. But with that, Chair, I have one item of information today, and that is the financial statements for the Renfrew County and District Health Unit. They are attached as Appendix 1. Mr. Chair and Committee, I would recommend that we do seek a motion to receive this information, just to record them into the minutes.
All right, thank you. I would seek that, I don't think it was contained within the report, but I would seek that motion to receive the audited financial statements for Renfrew County and District Health Unit for the year ended December 31, 2023. Councillor Weir, seconded by Councillor Grills. Any question or comment? I see the now lone member of the Board of Health that is on the Health Committee has vacated the room, but hopefully no questions. Are there any questions or comments on anything in the financial statements? I see none. All approved. Thank you. That is carried. And just to pick up on Mr. Kelly's comments, also I wish to extend, certainly on behalf of committee, council, and our community, that it is with regret, certainly, that I recognize Deputy Chief Farrell's returning, actually, to his previous career, though earlier I was suggesting to him, while he brings an incredible value to the paramedic service here at the County of Renfrew, his deep knowledge in moving back into the academic realm, he is probably going to have an influence on a lot more young folk, and perhaps not so young folk that are considering a second career, but those who would one day wear the uniform that he now wears and will occasionally wear moving forward. That I think that all of our communities probably served out of Algonquin College are so much better off for having Deputy Chief Farrell in returning to this role in academia. So congratulations, but we will be sorry to see you go, Deputy Chief. With that, I guess that's the only item on the report.
That's right. Just a motion.
So I would now seek a motion to approve the report as a whole, please. Councillor Wilmer, seconded by Councillor Yon. All in favor? That is carried. Now I would prevail upon Deputy Chief Farrell for the Emergency Services Department report, please.
Thank you, Chair. And to Council, I will just say that, yes, I will definitely bring the spirit of the Renfrew County Paramedic Service back to the college. There's a lot of innovation, out-of-the-box thinking, creative ways of supporting a community like Renfrew that is essential for the next generation to learn. So I'm definitely bringing that back with me. But thank you for that. I'd like to start item 1, discuss the MESA gathering. So on Wednesday, May 22nd, the MESA initiative was launched with more than 170 people attending in person and virtually. This represented approximately 50 organizations that came to discuss. Certainly would like to thank the Director of Long-Term Care for hosting at Miramichi Lodge in Pembroke. This was a joint venture between the County of Renfrew, the Ottawa Valley Ontario Health Team, and the Renfrew County and District Health Unit. The day included many powerful speeches and stories from lived experience and also from keynote speakers such as CBC reporter Omar Tobago Pacheco and what he's learned through his reporting on the opioid crisis locally and across the region. Also, Deidre Fahrenheit, former president and CEO of the Shepherds of Good Hope in Ottawa, and a panel of local organizations who shared what they have learned and to offer the community. A detailed report will be provided to committee in the August meeting. Item 2, our MESA coordinator. We're extremely pleased to announce the welcome Barbara Turney as our MESA coordinator position. Ms. Turney will be bringing her years of expertise in policy and in her ability to collaborate with all shareholders to bring people together to come up with creative and innovative solutions. She'll be working with the emergency services, community services, and development and property to help fortify the Mesa project. Her start date was May 27th, and since then she's been meeting with community partners and familiarizing herself with the programs and services, identifying the top priorities. So certainly want to welcome Ms. Turney back to the county, and I know she'll do a phenomenal job. Item 3 is emergency management. Attached in Appendix ES1 is a letter from Ms. Heather Levesque, Assistant Deputy Minister and Chief Emergency Management Treasury Board Secretariat, reporting that the County of Renfrew has met all requirements for the 2023 Emergency Management and Civil Protection Act. And so that is attached for you to review. Item 4, research. The County of Renfrew Paramedic Service will be hosting its annual research symposium on June 18th. Attached is an agenda, and you'll see that this symposium brings together leaders from not only across the region, but from across the world to discuss topics in paramedicine. It's always a well-attended event and a real great learning opportunity for our paramedics and from paramedics across the region who come to host with it. The community paramedics submitted a research proposal here, demystifying the role of community paramedics in community health failure management. What we see is that the community paramedics, as it says, sort of do their business sort of in the shadows of the larger healthcare system, trying to be part of the gaps, fill in those gaps to ensure the best possible care for patients. They work collaboratively with those healthcare professionals in hospital, primary care, and just trying to ensure that patients receive the best care possible. And so the team involving paramedic Matt Cruchet, Chief Nolan, created an abstract which will be submitted and was accepted at the Canadian Cardiovascular Society as a workshop at their meeting on October 24th through 27th. And there will be a panel discussion based on that. Item 5, I have a presentation on the introduction of the new AMPDS project and dispatch system and our role as commander. So,
maybe we'll just pause there because I think 5 and 6 are a little bit more detailed and involved. And just before we get to those, maybe we'll go back to items 1 through 4, and I will query the committee for any questions or comments. So, with that, returning to information item number 1, the Mesa gathering. Any questions or comments? I think that this was an outstanding enterprise. And I see it as being emulated or it is emulating, I suppose, the housing kind of forum that was held in April. Likewise, I see that there is, I just saw on social media, with respect to housing, there's going to be several forums right across the county of Renfrew, or mostly across the county of Renfrew. So I think that this very focused initiative really yields tremendous results. I was not able to attend in person, but I was able to catch just the tail end of Mr. DeBaggy Pacheco's presentation, but also the complete presentation by Miss Freyheit. I hope I'm pronouncing that name properly. And I thought that there was incredible insight to be gleaned from that. So a commendation, Mr. Kelly, to you and to the paramedics, community services, and of course, Mr. Davis's department as well. I think that this is integral towards being able to come up with some robust means of approaching this challenge that confronts us. Item number 2 on the Mesa coordinator. I'm certainly going to echo the Deputy Chief comments and welcome Ms. Tierney, which is kind of a sideways move. Ms. Tierney has been with the County of Renfrew for quite some time now. I think there might have been a brief interregnum, but glad to have you back within the friendly confines of International Drive once again. Item 3, the emergency management. Item 4, either of the research, either the symposium or the community heart failure management. Once again, I think that this speaks volumes of the data-driven approach that is foundational to the County of Renfrew Paramedic Service, whether it is something that we are anticipating doing or whether it is measuring the results from those things that we have already taken the initiative on. Many of them very innovative. I think that we cannot move forward without having that key component that is going to be data-driven and even data-supported. So once again, commendation. I think that the symposium now is probably the highlight for quite a number of paramedics on their annual calendar of this incredible opportunity for shared ideas and knowledge, recognizing, as we are projecting constantly here in Renfrew County, the best ideas come from everywhere. So I think that this is an outstanding forum for that. Moving on, then I will yield the floor back to you, Deputy Chief, for the presentation on the Advanced Medical Priority Dispatch System. I remind committee that you did receive this also from Ms. Van Starkenberger earlier.
Okay. So just at a previous meeting, I had discussed the implementation of the new dispatch system here in Renfrew County, and I promised to show everybody what it actually means. And in this presentation, we're going to incorporate the collaborative approach that the Renfrew County Paramedic Service has with our ministry-run dispatch center to actually affect response times and budget in a responsible way. So we're going to look at from a budget perspective, we're going to look at some of those hits that we take on meal breaks, end of shift, but it's also about ensuring that the paramedics are not overworked. Their job is stressful enough. If we can work together to ensure that the medics have appropriate downtime to recover from the previous call, to be at their full capacity for their next call, and that's really what's important here. And so what we did is we introduced a commander in the CAC Center. And this individual, Commander Paroli, his function is to really be that in between the operations of the paramedic service and the dispatch center. And you can see on this pie chart that the majority of his time is spent working collaboratively with the frontline duty supervisor to ensure that the daily operations are as effective as possible. In his position in the dispatch center, he has access to a large amount of data we can then extract to improve our system moving forward. And so part of his day is looking at that data, collating it, and presenting it to his fellow commanders, to myself and the other deputy chiefs, and to Chief Nolan to make those important changes to the system to get the highest performance possible. And then the small part for him is to actually support the crews on scene, clinical questions, getting out on the road, having some clinical ability as well. And so just for comparison of how this impact has happened. So with the commander being brought into the dispatch center in early 2023, we can see that we saw right off the bat a 25% decrease in meal claim comparison month to month. So a pretty significant impact just by having somebody with that lens working with the dispatchers to ensure that paramedics were getting their meal breaks at an appropriate time based on collective agreement language. When we looked at shift overrun comparison between those 2 months, what we see is a decrease, but not that dramatic. So we knew we had some work to do. And it is about that time that council approved the upstaffing of an evening shift for 2 paramedic vehicles. And so working with that upstaff, with the commander and dispatch, and then knowing that we were having a rollout of a new dispatch system, we thought, before we make massive changes to our deployment plan, let's see what effect we can get from that to have an impact on here. And so we'll look at, introduce you now to AMPDS, so Advanced Medical Dispatch, Priority Dispatch System. And so what is this? This is very much about getting the right resource to the right patient at the right time and ensuring that the community can count on, when they're having that most critical event, that there will be a paramedic available. We've all heard in the news coming out of Ottawa, these level zeros, no ambulances available, all of that type of nightmare scenario. Thankfully, that is really a very infrequent, almost negligible event here in the county. With the introduction of AMPDS, it really focuses on those most life-critical events and making sure that an ambulance is, in fact, available to us. So what is AMPDS? Well, this is a research-backed dispatch priority system. It's internationally recognized, and it does have its own medical director to oversee the policies and priorities and triaging of patients. And this is a learning system, meaning that as we gain more data and more knowledge about how this system impacts the community, we do have an ability to adjust to meet the demands of our own community. And I'll talk a bit more about that in a moment here. So we'll look at a little bit of data here historically, just to give some context. So before we had MPDS, we had another DPCI, which is a Dispatch Priority Card Index. And you can see that the code 4 calls, those highest level calls, are the majority that we were sent on. That means lights and sirens. That means regardless of what's happening, we have to send an ambulance. And what we knew, and continue to know, is not all of those code 4 calls were true code 4. It was almost like the system was overshooting to make sure they didn't miss anybody. The challenge, though, is that it's very hard on the system, and it's unsustainable. So when we look at all of that number of priority 4 calls, 58%, when the paramedics get there and assess those patients on CTAS, which is the Canadian Triage Acuity System, a standard tool used by all hospitals and all paramedic services, we see that CTAS 1, that most critical life-saving moment, only represented 2%. So we went from responding 59% to lights and sirens to only really target 2%. You can see that doesn't equate. CTAS 2 are still very sick patients, but even still at 19%, there's a massive overcall. And you can see that here at 50% being CTAS 3, which are, still emergencies, but they're not time critical emergencies. Yes, this individual needs to speak to a physician, but does that have to happen right now, or can we use some other tool? And that's what AMPDS has the potential to introduce to us here. And the numbers when we look at return priorities is even more dramatic. So of those code 4s, that massive number, only 13% of them are actually going back at that same level of acuity. The majority of them are these priority 3s. Need to see a physician, but does that have to happen right now? Can we use our other tools, our community paramedics, our VTAC system, our assessment centers, to ensure that these individuals who need to see a healthcare professional can get it, but try and offload that burden from the hospital where they cannot handle this caseload, from our frontline resources. It's a finite resource. We have to respect it and treat it well. Change. There we go. So just some looking at the data out of Ottawa and Toronto, and I'll focus on the Ottawa data. So they ran some numbers here and recognized, so similar to us, 77% of their calls really large number were sent out as code 4. When they broke those numbers down and implemented them into the new process, Ottawa started with MPDS about a month before we did. What they saw is that of those highest level calls, only 2% were those what they call CTAS 1. MPDS uses a color system, so purple. A lot of, a larger portion into the red, still urgent, emergent, time critical, but still a significant portion getting down into the orange and yellow. So those code 3, yep, should see a healthcare professional, but does it have to happen right now? Not necessarily. Okay, and so this has a real impact on our ability to utilize our resources. So what did this bring? Well, this, unlike the previous system where we would create a deployment plan and then we would hand it off to the dispatch center and they would then implement it, we were now able to look at this, what they called the matrix, which is basically every type of ambulance call or 911 call that occurred. We were able to identify who and what resource we wanted to send to it. So we look at, did we want to send an advanced care team? Did we want to send a primary care team? Did we need to send our Sierra specialty unit to it? Did we have to notify a commander? Do we need to bring in an allied agency? We went through, we spent hours and hours going through each one saying, this is the best resource for it. Again, to better define who we send and who we hold in reserve. We then imported that into our deployment plan, changed our language to make that line up a little bit better, and it's been a learning process moving forward from that. So what does this mean to the public? Well, for one, it means that the dispatcher is going to spend a little bit longer with you when you call 911. They're going to get a bit more accurate information to better define what the emergency is. We've now taken our 2 high priority calls, code 3 and code 4, and we've now divided them into 5 colors, again, to better define each of these emergencies. The dispatchers will gain more information about scene safety for both the paramedics and the patients. And there's an improvement in the medical care provided by the dispatcher to the person on scene while they're waiting for paramedics to arrive. Better CPR instructions, airway management, deliveries, much more robust medical information that they'll share. Again, trying to start that care before the paramedics arrive. With a system and vehicle status, we have a much better sense of where everyone is and what they're doing. And so this allows our commander and dispatch to then ensure that meal breaks are occurring at an appropriate time frame based on the collective agreement, that we're not having trucks go into unnecessary overtime. If a ambulance and a paramedic crew needs to transfer a patient from Pembroke Regional down to Ottawa, is the vehicle that's about to end their shift, is that the most appropriate, knowing we've got a 2-hour travel time, likely an offload delay at the Ottawa hospital, and then 2-hour travel. So the vehicle at the end of their shift, probably not the best one to go. Let's find one that's more in the middle of their shift, so we will avoid that overtime. And so this system really gives us the ability to manage that much more appropriately. And so these are the color groups that we see, green, yellow, orange, red, and purple. Purple being the highest priority, and that time critical for those interventions that are life-saving. So, we talk about cardiac arrest, we talk about, pediatric choking, those types of emergencies where the seconds truly count. Then go into red, still emergent, still time critical, but not the highest level. And this equates to, again, as I said, the CTAS level, which is a recognized triaging tool across the country. So again, the purple, those emergent, time-critical events where, and the system really is focused on these calls. We actually have an ability, we will hold some of the lower priority calls to ensure that that ambulance is there for when the member of the public calls for these absolute emergent calls. There's nothing more scary than to know that you have to wait when your family member is in absolute crisis. And the system is designed to make sure that there will always be an ambulance available to you for those events. The reds, they are emergent. There is a potential for life threat. So, we talk about heart attacks where there is a window there that we can respond into. Orange, still lower acuity, but we talk about things like people who have known seizure disorders, who are out of their seizure, would be considered an orange. Someone who's had a stroke, who's outside of the window of therapy, they would be in an orange. So, we talk about last moment seen. So if somebody wakes up in the morning with stroke-like symptoms, there's no way to know when that happens, and the therapies for that treatment are very time restricted. And so that where we capture in an orange. Yellow, these are your much less urgent. So you can see in the slide, the fender benders, no one's injured, maybe some sprains, strains, that type of thing. And then greens, very mild symptoms. And so we can take all of these, and if you reflect back on the chief's presentation at last committee with, I think he described it as an avocado sort of diagram, it's these green, yellow, oranges that we're going to look at using our community medics, our assessment centers, the VTAC, to again, pull these patients out of the 911 system and get them managed by a more appropriate system. Still have access to a healthcare professional, still talk to a physician when required, but not on the burden of the 911 system or the hospitals, which is really a priority. What it can mean, because we are prioritizing those highest levels, if you're calling 911 for one of these lower priority calls, you will wait. You will wait longer than maybe you would like to wait. Maybe you were expecting to wait. The dispatch now has an individual in there whose sole job is to call you back and make sure nothing's changed. Are you okay? Has anything gotten worse? Do we need to reprioritize you and send a vehicle more quickly? Maybe provide a few more instructions for you. Again, this is all based on protecting the resources for those highest level of calls. So there is a check system built into it to ensure that you don't just call 911 and then are left to your own devices, that they will reach back to you to make sure that on an ongoing basis, you're still okay, nothing's changed. Is there anything else we can tell the paramedics that might change their priority response to you? And so we divide into two categories. We have a closest unit, so your purples and reds. The closest unit will always go to those because we recognize there is a time sensitivity to those calls. The orange, yellow, and green, where the time isn't quite the factor, we talk about best unit. And that can mean someone who's not at the end of their shift, so we can manage shift overrun. We can talk about meal breaks to ensure that the paramedics have an opportunity to have a meal, to rest, so that they are ready for that next call. And really balance the coverage across the entire county, and again, reserving a couple of paramedics for those highest level calls. As I said, this is a learning system. So we are part of what's called a dispatch steering committee, where we sit down with members from the Ministry of Health and our local CAC center and basically ask ourselves, how's it going? Is it working? Is there something we need to change? As we recognize this is a learning system. You can't take something that's applied to the entire province and expect it to work perfectly here in Renfrew County. We are very unique. And so we're able to tweak it to our uniqueness. And so this is a regular, and this feedback comes from the command staff. It comes from frontline paramedics. If they see an issue, they're like, this isn't working the way it was intended. They have an ability to forward that information up where it sits at the committee. We discuss it to see, can we deal with this internally, or is this more of a systemic problem that then goes to a provincial committee, which the chief sits on, and they discuss it to say, yep, this is a gap that we didn't recognize, and we're going to make a system-wide change. So that learning ability within the system is there. So again, what does it mean for the residents and visitors? The biggest thing would be they're going to spend a little bit longer on the 911 call, and for the lower priority calls, they're likely going to wait a little longer. But there will be that constant check-in. So if we now compare that a year forward, 2024, when we look at our meal claims, so from April to April, we see about a 25% decrease in meal claims. From May to May, again, about another 25% decrease in meal claims. And from April to May, a further 28% decrease. So real impact by bringing all of these tools together, we can see a real fiscal impact here. When we look at shift overrun, again, bringing all of these tools together, from month to month, we see, my eyes aren't that good, we see a decrease of 30%, and then again, close to 40%, and month to month, 13%. And so again, that's the combination of the new dispatch system, our up staff, and having the commander and CAC to sort of organize all this, work collaboratively with the dispatchers to ensure that the best vehicle is being used for these lower priority calls. And probably one of the most important elements of this is our response time and its effect on our response time. You can see in 2022, and we look at CTAS 1, right? Those highest level of calls, because those are where it really makes a real difference. In 2023, we see that we had these 19 events and comparative time frame in 2024. This is a 1 month. We see 33 events. And the real nutshell is that, if you look at your response times in 2023, about 12 minutes, almost 13 minutes for this, down to just under 7 minutes. A real impact on providing time-critical interventions to those that need it the absolute most. And with that, I'm happy to entertain any questions.
Thank you very much. I found in going through this, in particular, probably the last half dozen slides were quite remarkable. Invite any questions or comments from committee. I'll prime the well, I guess. You had said, Deputy Chief, that this is organic, or that it is a learning environment. It strikes me as this is a precursor to artificial. This is non-artificial intelligence, the good old-fashioned kind of intelligence. But I think that this probably is giving us a bit of a glimpse into AI, and AI is simply the means of going through an incredible amount of data in a very time-compressed situation. But I see what is possible with what is being done here, and in fact, the changes on both the meal comparison and the shift overrun. So just the commander in the CAC made a substantial difference in 2023, at least on the meal side, not so much on the shift overruns. But now with the priority dispatch, we're seeing dramatic change, which is reflected in two different things. The very last slide on page 15, so the events almost doubled from 2024 over 2023, but the response time almost halved. So for those that are truly in that red or purple category, where every minute is an eternity, you've taken off almost half an eternity from the response. The second thing, as the funding agency for this, the slide on page 14, the hours, so 106 decrease hours in April 24 over 23, and 133. So that's translating into real dollars that we have an availability also for our paramedics to be responding to emergent situations. The nature of paramedicine is not that we're a portable emergency room waiting outside the doors with a patient in it. It is to be able to respond out into the community. So very, very excited about what this is meaning, and not just what it is meaning for today, but what it is signaling about where we are moving forward. And it almost has overtones of the earlier delegation as well, which is we are recognizing the scope change, and the dispatchers are not a completely separate entity. They are part and parcel of the emergency response that we have available to our community, and is utilizing them a lot more in being able to, again, the adage of the right response at the right time in the right place. So I think that we are seeing substantial benefit from this. So thank you very much for your presentation. Another opportunity. Any further questions or comments? Councillor Nicholson.
Thank you, Chair. Just, and I appreciate the presentation. It's actually a new background. I liked it. But the geography as tied to some of those facts that you provided, I know we had that, I think it was as a preliminary brief to the budget for last year where we did the heat map. With that in mind, and the numbers that you presented, especially with the second or third last slide on the CTAS 1, are you noticing like a geographical change to some of those previously red hot areas?
No. Looking at, just where the population rests in the county, those calls are coming from the same areas for sure. Again, it's our ability to ensure that there's always a vehicle available. That's the key element, right? That there's always a paramedic, be that a fully staffed crew or working collaboratively with the community paramedics, right? The other element to having a commander in dispatch is that individual is now a link to our community paramedics, which the dispatch never had before. And so if there is a community paramedic part of their day doing their tour, if they happen to be on top of where a purple or a red is, that commander in dispatch can message them because they've got full access to all the vehicles in our fleet and say, look, I've got a purple call, you're right on top of it, can you go? Absolutely, right there, and we've made real impact.
Thank you. Councillor Weir, please.
Thank you. Through you, Chair. I know time to time we have paramedics down in Ottawa that get rerouted to their calls. How often do we have paramedics from other regions get calls in our area?
I don't want to say it doesn't happen, because it does, but certainly with the use of MPDS, and again, that ability to hold a vehicle in, we divided the county up into 3 regions, and to be able to hold a vehicle in each region, it really reduces the need for another agency to come in and provide care. Does it happen? Yes, it does.
Yeah, I would expect also, given that Ottawa is the tertiary care, that it is much, much more likely that our or any of the services that are surrounding the tertiary care region are likely to be in that region for that response. There was one thing also, and thank you to Councillor Nicholson for reminding me. So for the what will now be purple or red, there is an incredible value in having those ERVs or emergency response vehicles that the community paramedics have. The strength of an emergent response is not that we have a bus there quickly, it's that we have a person that knows how to respond to an emergency is there quickly. The transportation comes afterwards. So there's an incredible value that the MPDS had not even, we were out in front, let us say, of the medical priority dispatch, given that we had kind of pre-positioned through our community paramedicine program in our broad geography here, almost pre-placement. So there's a value in that. But I'm also wondering, and I'd made a note of that on my sheet here, particularly when there is a challenge on any particular day, is it possible that ERVs might respond in orange, yellow, or green situations as well?
I would certainly say that is the vision of the chief, is to look at the community paramedics and say to them, we recognize that the green, yellow, and orange are not time sensitive. So do what you do as an expert in system navigation and bringing that eye and see, does this patient actually need to be transported to hospital, and we'll continue that transport unit, or can we book an appointment for you at the assessment center? can we get you on through the telephone, through the VTAC system, talk to a community, or can I manage it right here, right now with you? And so, again, I would see as we continue to mature with this system, that will become a larger part of the community paramedic day. We'll be decanting these lower priority calls to pull them right out of the 911 system.
Thank you. And again, consistent with the earlier presentation, I think that as much of the navigation as the system can do on behalf of the user is certainly a big win in terms of the service that we provide in the health sector, recognizing that there's always going to be a time when people will have to navigate and the system cannot accommodate. And even to the instance, I mean, if it's a green, perhaps the dispatcher's not allowed to say this, but perhaps you can take your own car. I know with VTAC, we actually do have that. If they phone and there is, as they are going through their kind of triage, it is, VTAC is not the place for you, hang up and phone 911, or directing you to go to the emergency. And again, it is from the perspective that we don't have an ambulance available for you, but we'll call you every couple of hours to see if things haven't changed. And that is as the let's say the worst case scenario. But if there is an option to say, okay, well, right now we are challenged in terms of our resources, but there is a CP that is only 15 minutes away, perhaps we can schedule, there might be an opportunity for them to come by, we will continue to contact you. Ultimately, it is not we don't have an ambulance and we'll send one when we do. It is kind of like when you're having one of your utilities repaired, we will be there sometime that day, which is not particularly helpful. So I'm very pleased at all of this, but I think that the fact that we have such a broad community paramedic program, it allows us, I think, to really augment what the AMPDS is doing for us. So thank you, Councillor Lafreniere.
Just a quick query. Is Ottawa using the same priority response system now as we are?
They
Perfect.
are. Yeah, they started a month before us, and we're seeing the benefit of that.
Yes.
In that, because not, as you say, we used to go into Ottawa to service these code 4s, and now that they recognize that those true emergent calls are such a small portion, that's really insignificant event now.
Yeah, I assumed, that's perfect. So that ripple effect now is seeing a reduction in the calls that we have to report to in Ottawa.
Exactly.
Thank you.
Absolutely.
Yeah, and I think that this slide was on page 7. I'm not sure if it's the top or the bottom one. I think that Councillor Lafreniere was the top of page 7, where 77% of their calls were in that code 4, whereas using the red and purple, it would be under 40% of their calls. So I recognize that those that are dialing 911, when you get to that point of dialing, tapping on your phone, it is an emergency in your head. But of course, the system must have a rational approach to this. So ultimately, it is substantially less than that. It is almost half that are actually that code 4 priority. So yeah, I would expect to see some substantial savings, and this kind of ties into Councillor Weir's question as well, that we are less likely, even if we have offload delays at a facility in Ottawa, that there is less likelihood that we may get called to perform a within-region response. So I think that there is incredible benefit. And again, I think that what it is doing is simply hinting at what AI might be providing us in 10 years' time or so. Anything further? There is none. Thank you very much, Deputy Chief. And finally, then, I will prevail upon you for item 5, and I recognize that we also have Commander Libby with us, and to answer any questions or comments on the final item on your report.
Thank you, Chair, and through you to committee. So item 6, the vehicle purchasing program. You'll see there's an attached appendix, ES3, which is a sole source memorandum for the purchase of paramedic service vehicles in accordance with County of Renfrew Corporate Policy GA01. procurements of goods and services, non-competitive processes, subsection 22.1 for Demers ambulance manufacturers. Just really speaking to some of the challenges around having only one source of emergency vehicles to purchase here in the province. The province of Ontario has very strict certification processes, and to which there is only now one provider of ambulances within the province of Ontario. And as you'll see in the appendix letter from Commander Libby, Acting Deputy Chief Libby, that the issue that's coming to head here is that historically we bought our ambulances pretty much complete, ready to go. And what's occurred is that the stretcher manufacturer, Stryker, is not supplying the ambulance manufacturer with stretchers anymore. And so what used to be a bundled package that we could, purchase from Demers is now going to be split into two. You can be cynical about this, or you can think about, really it's actually to a benefit to us, because what's happening, because of the supply chain issues, we would order an ambulance and then start paying for the warranty on a stretcher that we did not have access to for over 2 years. So that's useless warranty for us. And so Stryker recognizes this and says, look, buy your ambulance. When you get it, we'll give you a stretcher so your warranty can start the day you receive it. So although it is fiscally painful, it's actually long-term wise a benefit to the county.
Thank you. A little bit complicated. The actual report can be found on page 33, and my apologies, Acting Deputy Chief Libby. Any questions or comments? Councillor Nicholson.
Thanks, Chair. And it's a question not related to the content. It's clear, and I appreciate the detail provided was sufficient, so thank you. But I'm curious in terms of the procurement process, and just because I don't know enough about ambulances, I noticed for fire trucks, as an example, where the lower tier municipalities are able to use Canoe, and there's a number, the provider goes through Canoe. Is that same? And in some cases, we have suppliers from the U.S. providing these resources to meet provincial standards. Is that an avenue that's available through AMO, using Canoe or those kinds of purchasing programs that are already available?
Thank you, Chair, and to Councillor Nicholson. We haven't investigated using something like Canoe, but to my knowledge, due to the fact that there is one ambulance manufacturer in Canada, and we order from them directly, my suspicion would be is that Canoe would not be an option when you look at purchasing fire trucks or snow plows or whatever the case is. They can purchase them from a variety of different vendors and different suppliers, but I think simply because we're sort of painted into the corner to sole source from Demers. Traditionally, there used to be two manufacturers, Crestline from Saskatchewan and Demers from Quebec. Those two companies have in the last couple of years have actually merged and been purchased by Demers. So now you can order the one ambulance or the other, but it's all through the same company. So, again, to Deputy Chief Farrell's point, we're lucky in Ontario that we do have, strict certification. It means that our trucks are very safe and they're well tested. But again, we pay for it, and the fact that right now, there seems to be a real bottleneck as far as receiving these vehicles, and the issues that we're having as a paramedic service is not in isolation to the county of Renfrew. It's something that's happening province-wide, and we are working on a working group to discuss these issues with the ministry, and I hope that answers your question.
To follow up a little bit on that, perhaps you can shed some light, as I understand it as well. So there's a sole source manufacturer in the country, but I think also and I'm assuming this would be so for all provinces, but in Ontario, I think that they are pre-qualified. I think that the province itself recognizes the qualified vendors of ambulances. So in this instance, if there is only one recognized, then there is no alternative even to go, not necessarily across the country because there is no option, but even to go into the United States would not be an option unless there are manufacturers there that would become pre-qualified by the province. Is that correct?
Yeah, that's correct, Chair. And for example, for us to put a Ministry of Health radio in one of our vehicles, the ministry wants assurances and proof that the vehicle that we're putting that radio into is certified for use in the province of Ontario. So they're quite strict and rigid, but like I said, there's purpose and meaning behind that.
Thank you. Any further questions or comments? Councillor Nicholson.
Yeah, thank you. And I wasn't, I appreciate that. I wasn't trying to say, could we get a better deal, but just fast line the procurement. Even this, you wouldn't have to do sole source. You'd be able to just do a call up on an existing offer. But I understand it's much more complicated than what it might appear to be. My second question just has to do with the extended timelines that we're seeing now in the vehicles. Traditionally, we've said ambulances are good for 5 years is our planning figure, and after 5 years, we want to replace them. And I know that we've picked 5 years because after 5 years, the expenses of maintaining them and certifying them and meeting all those strict guidelines becomes more expensive than just procuring a new one. This current constraint on supply is forcing us to extend that from 5 to 7 years. So we're now going to be able to have very clear data showing us how much it's going to cost to keep those 5 buses on the road for years 6 and 7. And my question then would be, with that data and the increased cost to the new buses, should we be re-examining the 5-year reference point? Should it be 6 years going forward?
Sorry, if I'm, just before I call on Acting Deputy Chief Libby, so what Councillor Nicholson is referring to, and I had this query on that I was going to get to momentarily, but so this is with respect to the ambulances that are going to be ordered this year with, at budget time, the expectation that we would take delivery. Thank you, Deputy Chief. I got surrounded by deputy chiefs. That would be received, or at budget time, we thought that they would be received in 2025. However, just in speaking with Dave this morning, so even those ambulances that we ordered in 2023 with an expectation of taking delivery this year, it's anticipated that we're not going to actually take delivery until next year. So our working life has not been extended, but the exigencies that seem to be continuing to exist in supply chain, et cetera, whatever it is, now seems to be a 2-year lead time. So my question was with respect to whether there would be budget implications for those 5 that were carried forward. And Acting Deputy Chief said, no, not to worry about that because we're not even going to get them in 2024. So there may be, and in fact assured me that the purchase price is going to be the purchase price even when we get them in 2025. However, we're not seeing a regime change of an anticipation. There is going to be, I suppose that was your question, Councillor Nicholson, piloting, unintentionally piloting, but the intention is to stick with the 5 years, and if there's going to be a continuing regime wherein it's a 2-year delivery, then we are going to have to advance our process, because the 5 years, I think we've established pretty good benchmarks on where those cost curves really begin to steepen. If memory serves, I think at 5 years we have about 300,000 kilometers. Okay, approaching 400,000 kilometers. So the expectation is if it's going to be a 2-year lead time, then the ambulances that our asset management plans say we need in 2025, then we should have ordered them last year. The ambulances that we need in 2026, we should also be ordering them this year. So that if we are intending to do that, there might be budgetary implications of actually putting a down payment on equipment that we're not expecting to get for 2 years. But I will invite the acting deputy chief to respond to Councillor Nicholson's comments on the metrics that might be associated with having to carry these ambulances. The ones that were supposed to be received this year aren't coming until next year. So we're carrying some older workhorses, and are we measuring the data on the costs?
I don't know if I can add a whole lot to that, Chair, but I'll attempt to do that. Agreed. It's perhaps at the point where we do have to take a bit of a different approach. In working with the manufacturer for about a year now since Deputy Chief Leahy's departure, I do get a strong sense that they also like to hold cards in a certain way that it limits our ability to sort of jump ahead of the queue. I think they're balancing, when you look at their facility, they're doing vehicles from, the upper United States and all across Canada, really. So I think there are ways maybe that we could investigate to sort of to get ahead of the game. But again, that being said, it's quite a convoluted process that we're into right now, and I do think we have to perhaps work with our friends in finance to relook at the way that we're doing our asset management plan when it comes to vehicles, knowing now that there was a 1-year delay, and now this order that we put last year is now going to be a 2-year delay. I do acknowledge the great work that our fleet mechanic does, Glenn, and he's meticulous in the work that he does, and I think, I'm quite confident in the vehicles that we do have on the road, even the ones that are getting a little long in the tooth. But again, that being said, with time, things do wear out and have to replace. So we will obviously keep an eye on those costs and as they increase. And again, it might be something that we have to relook at our approach and how we plan out these things, these assets, for sure.
Yeah, and I think, Acting Deputy Chief had alluded to that, I think that perhaps, along with Mr. Kelly, if the expectation is that this kind of lead time from order to receipt is the new paradigm, then there's going to be a cohort year where we're probably ordering 2 sets, ultimately, if you will, which was going to have budgetary implications, because ultimately the ambulances that we ordered in 2023 we're not now going to get until 2025. So the ones we're ordering in 2024, I wonder, are we not going to get them until 2026, at which point, at budget time next year, are we going to have to order both the ambulances that would normally have been ordered plus an extra year to be able to catch up? At some point, it is, I'm fairly certain that we're going to have confirmed that 5 years is the appropriate time span. But it seems that we're going to have to catch up to the new environment surrounding this capital acquisition, and that may actually be next year. That's not for us to determine today, but it has become increasingly complex simply ordering these ambulances, and in fact it's somewhat disconcerting as well if one of the things that is pressurizing the lone manufacturer in Canada is that they are also providing ambulances into the US, where we don't appear to have any American manufacturers inclined towards entering the Canadian market, because I suspect that what we are seeing is also the results of monopoly, and I'm not entirely sure that it would be as complex in a competitive environment. In any event, any further questions on this item 6 of the report? Seeing none, I would seek a motion to approve the report as a whole, please. Councillor Weir, seconded by Councillor Nicholson. All in favor? That is carried. It is 11:13. We're going to take a recess. We will reconvene at 11:25 sharp. Welcome back, everyone. Pleased to see everyone back in their seats. At this time, I would invite Mr. Blackmore to please take us through the long-term care report.
Thank you, Chair Donahue. Good morning, all. Your report begins on page 35. Item number 1 is an information item informing committee of 2 Bonnechere Manor PSWs participating in the University of Waterloo and Kite Research Institute research study examining end-of-life care. The end goal of this particular study is to produce a research-based documentary film intended to inspire end-of-life conversations with family, friends, and care providers in long-term care. Item number 2 concerns the recent purchase and implementation of automated medication dispensing cabinets for Bonnechere Manor and Miramichi Lodge. These new cabinets were purchased using medication safety technology funds and will significantly improve the availability of emergency drug stock, security, record keeping, and dispensing accuracy. The lodge was brought on a few weeks ago, and the manor is lined up to go live tomorrow. Item number 3, delegated authority approvals. It informs committee of a recently executed delegation of authority, Bonnechere Manor 2024-01 emergency generator replacement. Just this bit of a twist with regard to our procurement delegation procedure. CEO Kelly, would you like to? Shall I read the? Or sorry, Chair. Shall I go ahead and read the as it's presented?
I think that so this is a new feature. This would typically be falling under, I don't know, resolutions or bylaws, but with the delegated authority bylaw, this procurement is being done presumably by the CAO, though I'm uncertain. So there is not really a resolution or a background. I think that really as it continues to be an information item, so the information certainly has been, is contained within the report. I believe this is the last of the information items, though, before we move on to resolutions. Is that correct?
Correct, Chair.
Okay, so with that, then, I would invite committee to join with me. We'll return information item number 1, end of life care study. Any questions or comments? I'm always pleased when staff from the County of Renfrew are participating in this. I think that there is a perspective that rural Ontario brings, and I think that notwithstanding Ms. Mersman's comments earlier, I think truly we are unique here in the County of Renfrew. I know everybody thinks they're unique. Everybody thinks they're above average too. In any event, very pleased, so please do pass on my commendation to those who will be participating. Item 2, the automated medication dispensing cabinets. I see none. And on the generator replacement. Just a single comment, very pleased. It's a win-win while being the most economical. The County of Renfrew is always my priority. I think that it is fantastic that, in fact, it is a County of Renfrew vendor in this instance. And it's only coming in at about 75%, give or take, I think, of anticipated budget. So very pleased on both of those counts. With that, any further question? I see none, so moving on then to resolutions. The second item number 1.
Thank you, Chair. The second item number 1 is a resolution, multi-sector service accountability agreement and Schedule F form of compliance declaration. A recommendation that the Health Committee recommends that County Council authorize the Warden and Chief Administrative Officer, Deputy Clerk to sign Schedule F Declaration of Compliance issued pursuant to the Multi-Sector Service Accountability Agreement for the County of Renfrew, Bonnechere Manor Senior Adult Day Program.
Thank you. I would seek a motion, please. Councillor Weir, seconded by Councillor Grill's. Background, please.
Chair, through to committee background, Bonnechere Manor has been operating a senior adult day program in Renfrew since February 1997. The program is available to residents in and around the communities Monday to Friday from 8 a.m. to 4 p.m. Access into the day program is through the home and community care support services. For the continuation of funding for Bonnechere Manor Senior Adult Day Program, Ontario Health is requesting a signed Schedule F declaration of compliance for the period of April 1, 2023 to March 31, 2024, which is attached as Appendix LTC 1.
Thank you, Mr. Blackmore. Questions, comments? I just noted one item here, and this probably is for Mr. Kelly. When we were discussing at the May County Council the delegated authority, MSAWs and LSAWs were one of the examples that I cited. Now, I do recognize that council, I guess, is the board of governance, or there's a specific role within long-term care. But this, I did wonder, seems to fall within 9824, Section 6, in terms of the delegated authority. I wonder if you could clarify why this still is requiring council's approval?
No, thank you, Chair, and it did, and this was a conversation I had with Mr. Blackmore. When we look back at, oh my gosh, the inspections and you recall we met with the inspectors and the conversation we had with regards to the CAO and the executive, the chair and the warden, being engaged at all times with compliances and inspection reports and otherwise. I felt that this item, well, arguably could have fallen under delegation of authority. It should come to committee and council for your review and ultimately your agreement with compliance, just to show that you indeed have reviewed the compliance reports and have signed off on it, as opposed to just circumventing, if you will, the chair.
Okay, so if I'm understanding, then it is mostly as a nod to the accreditation as opposed to appropriate protocols in terms of what the ministry requires.
Not necessarily just accreditation, just to keep you, compliance is compliance, and I feel again that we had the time to review this with committee and council, so it closed the loops as opposed to needing haste, and again felt that items of compliance should really come by committee and council just for their review. But Mr. Blackmore can fill in the blanks.
Yeah, if I could, Chair, thanks, CEO Kelly, to you, Chair. This is not an accreditation item, although accreditation certainly identified, wanting to be assured that the CEO, our governing body, is aware of, our compliance with accreditation. This is specific to our agreement with the Ontario Health East, that we're meeting the obligations of the program. And we just want that concurrence of committee and council that we're all in agreement that indeed we are.
No, thank you, and perhaps I confused the situation. I recognize that it is not, but the points that Mr. Kelly was making with respect to the meeting with the inspector, et cetera, that was very specific to the accreditation, and in fact, I think it was one of the things that we were moving towards. I don't know if it was, obviously it was not on a monthly basis, but I think that there were more reporting coming forward here because that was one of the areas suggested by the accreditation. So in terms of those specifics that Mr. Kelly was raising, that was accreditation. That was not the ministry that was meeting with us with respect to that. In any event, any further question or comment? Seeing none, all in favor? That is carried. Thank you. And moving on then to page 41, further resolution, please. Oh, and another number one.
So, thank you, Chair. Through the committee, next is a resolution seeking approval for a business case for an additional resident care coordinator for each of Bonnechere Manor and Miramichi Lodge. The business case can be found on page 41. The resolution, recommendation that Health Committee recommends that the County Council approve 2 new full-time staff and complements, one each at Bonnechere Manor and Miramichi Lodge, designated as resident care coordinators, and that the Finance and Administration Committee be so advised.
Thank you once again. I would seek a mover. Councillor Yon, seconded by Councillor Wilmer. Background, please, Mr. Blackmore.
Thank you, Chair. Through the committee, background attached to Appendix Long-Term Care 2 is the business case staff and report requesting committee support for the addition of a new resident care coordinator in each of the County of Renfrew's long-term care homes.
Thank you. Discussion. So in reading this, ultimately, each of the homes now has 2 resident care coordinators. The mathematics are contained within the business case. This will, in increasing it to 3 from 2, it will reduce 33% of the workload on each of the current resident care coordinators. However, as I understand it, the challenge is not just confronting us today, that there has been an increasing workload and an increasing expectation. And of course, the province finally and approvingly moving to the 4 hours of care and providing substantial augmented funding for said, it is creating some workload challenges. Is that correct, Mr. Blackmore?
That's correct, Chair. So yeah, as you said, this is basically, it's been building up for some time now with the advent of increased supplemental hours. So the PSW, RNs, and RPNs, these are the very workers that the resident care coordinators supervise. So with increasing that staffing, there's an element of required supervision, mentoring, coaching. And then on top of that, all the more recent Fixing Long-Term Care Act and the enhanced compliance, where there was a day when a compliance inspector would come in a couple times a year. Now they're arriving in teams of 4 and 5 and are coming once a month. And it's it's all to the benefit of long-term care, overall care quality, but it's not without a price in terms of health human resources, and the management component is certainly a part of that.
Outstanding. So the demands that we, the operators of long-term care, have actually been making on the province towards increasing the level of care, and of course the experience through COVID that has led to more compliance inspections and reporting, et cetera. They now have had a commensurate increase in the workload, particularly in this job category of resident care coordinators. So it now behooves us to recognize the need to respond appropriately.
Chair, if I could,
please.
Mind if I could just add a few more points, just with regard to the resident care coordinator position itself. It's a registered nurse, and the registered nurse, there's some issues with compression with regard to what a resident care coordinator's wage and an ONA RN wage. So now's the time to improve the workload aspect of that to help with regard to retention as well. I just wanted to mention that as well.
I'm very pleased that you did. Ultimately, in the end, the expectation and the workload, the demands upon the resident care coordinator position at both the Lodge and at the Manor have increased dramatically. Hence the business case for this. Any further questions or comments? I see none. All in favor? That is carried. Thank you.
Thank you, Chair.
Moving on to your 4th item, number 1. Please.
My 4th, number 1, is a business case for staffing for some personal support workers for Bonnecher Manor. And I'll just preclude this with to identify that to follow this is a PSW business case for Miramichi Lodge. And reading the two, you might think it's they're a little diametrically opposed. One, I'm asking for increased full-time. The other, I'm asking for increase our part-time ratio to full-time. And just to preface all this with the knowledge that these particular PSW positions are fully funded through the supplemental funds that we have not yet exhausted, nor will we when we attempt this, what is basically a first stage of staffing adjustment. But anyway, just to essentially both homes are a little divergent in terms of their full-time, part-time ratios. Bonnecher Manor has a higher full-time to part-time ratio. Miramichi Lodge has a higher part-time to full-time ratio. So we're just basically, this business plan is a first step to, business plans is a first step to kind of bring them more to the center in terms of full-time employment, which is certainly desired by many people, but with full-time, you also need a certain part-time element to support the full-time when they're off vacation, sick, things like this as well. So with that, the recommendation for the first business case is that the Health Committee recommends that County Council approve the redistribution of hours of 4 full-time and 3 part-time personal support worker rotations to existing personal support worker part-time rotations, and that the Finance and Administration Committee be so advised.
Thank you once again. Committee, I would seek a mover, please. Councillor Grills, seconded by Councillor Lafreniere. Background, Mr. Blackmore.
Background attaches LTC 3 is the business case staffing report requesting committee support for the reduction of full-time and part-time rotations designated as personal support workers for redistribution at Bonnechere Manor.
Thank you very much. I did kind of note the disparity between the Lodge and the Manor, but I am capable of holding two independent thoughts in my head. Keep in mind that I blow on my tea to cool it off, and I blow on my fingers to warm them up. So you can have diametrically opposed situations, and yet they still make sense. Any further questions or comments? I see none. All in favor? That is carried. Moving on then to the fifth item and final, item number 1.
Thank you, Chair. That's a business case staffing report for personal support workers, Miramichi Lodge. A recommendation that the Health Committee recommends that County Council approve 14 full-time personal support worker positions at Miramichi Lodge, and that the Finance and Administration Committee be so advised.
Once again, mover, please. Councillor Weir, seconded by Councillor Nicholson. Background, Mr. Blackmore.
Thank you, Chair. Background attached as Appendix Long-Term Care 4 is the business case staffing report requesting committee's support for 14 full-time personal support worker positions at Miramichi Lodge.
Thank you. Again, questions or comments? I see none. All in favor? That is carried. Thank you. I believe that does bring us to the close of the long-term care report. So with that, I would seek a motion to approve the report as a whole. Councillor Lafreniere, Councillor Wilmer. Any further and final opportunity on the long-term care report? Any item? Seeing none, all in favor? That is carried. Thank you. Just returning to the agenda. The Board of Health minutes are attached. I do note that the member delegated from County Council to the Board is present, so if there are any questions, perhaps Councillor Nicholson can answer them. I would seek first a resolution to receive the minutes of the Renfrew County and District Health Unit Board of Health minutes for March 26, 2024. Councillor Yon, seconded by Councillor Weir. Any questions or comments? I see none, and to the look of relief from Councillor Nicholson, all in favor? That is carried. Is there any new business? Councillor Nicholson.
Not sure of the appropriate way to ask this, but two things that came up in today's proceedings that I was wondering if there was more information available. The one is just with the changes with the PSWs, increases and decreases, but overall increase. Do we have any appreciation for the flow or the generation of PSWs from Algonquin College locally? So that's the first one, and whether or not you choose to, you want to address it now?
Perhaps one at a time. I don't know if Mr. Blackmore has that at his fingertips available today. Perhaps that is something that could come back to, now it would be the August Health Committee. And if you do have that, feel free to share.
Not sure that I have an exact number, but perhaps a question to help clarify to bring back a number. But I do know that historically, we do, for whatever graduating class that comes through Algonquin College, they would have done a preceptorship at either of the homes. So we certainly get a percentage of, whatever that graduating class is. The number, the exact number, I can't tell you, but I can probably get you that for August. Unfortunately, gone are the days of more recently where we had the in-house classrooms. They just did not have the critical mass to support in-house, what we call the living classroom that we employed at both Bonnechere Manor and Miramichi Lodge last year. That they didn't have the numbers to go forward with that this year.
The reason I ask is and sorry, Chair, if I can continue.
Do carry on.
It's just to make sure that Algonquin College is aware that our demand is going to increase by X number. So if they're planning sessions or looking at a living classroom opportunity, those things present itself. And just from a municipal perspective, are there levers we can pull? Is there pressure we can apply to now meet the positions we're now proposing to council that they should approve?
Just preceding Mr. Blackmore, and I would invite you in momentarily, I've lost track now, actually, of when we were confronted with an inordinate challenge, particularly in PSWs, of meeting our needs. I can probably go back 6, 7, 8 years on that, and certainly my understanding that Algonquin College is quite happy with the programs, the living classroom that we're doing. The challenges of the enrollment numbers simply aren't there to support that. So it would seem to me that it is primarily beating the bushes to try and encourage folks to enter the field. I know that we do qualify, I think, for those regions that have enhanced bonusing, et cetera. And even with that, the challenge still remains. We are now hiring international students at the Manor, but I would invite Mr. Blackmore to augment that.
Committee may recall that Algonquin College made a presentation to us not long ago, and they identified the challenges with recruiting students. This, despite incentives offered by the province, to the point where they've engaged a number of international students with assurances that no international student has taken the seat of someone local that would have otherwise joined into the program. My point is they're keenly aware that there's a demand and that there's incentive on behalf of the province, and even so far as not only the provincial incentives but county. We'd also engaged our own incentives for hiring with somewhat of a success, I would say, initially. But here we are. We're still in a situation where we're trying to recruit internationally at one home. Which our hope is to at one point not be reliant on staffing agencies whatsoever, which one home we are, one home we're not. But that's on a call recently with the Eastern Ontario Wardens Caucus Administrative Group, throughout, and I would certainly Eastern Ontario, but I would suggest probably Canada as a whole, it remains a very much the dominant task ahead of us in terms of getting us to where we need to be in terms of the care we want to provide.
Thank you. Again, 51,000 is an enormous number. Follow-up.
Is the second question just had to do with the presentation from the OVOHT. Sabina had mentioned a report from the UK or a study from the UK that was going to indicate more of projected long-term care requirements or aging health requirements. I'm wondering if we have our thumb on that pulse when that report comes out. Can it come to us in some way?
Again, I would defer to Mr. Blackmore, and if it's not at his fingertips, perhaps he could contact Ms. Mersman. When she was making her presentation, I actually made note of that, and I forgot in the questions, but we are already seeing that. The acuity, it is somewhat at odds, I think, with the comments of Ms. Mersman, but we are seeing such a dramatic uptick in the acuity that people are apparently leading more healthy lives until they're not, because our experience now on our CMI is that on intake, we're seeing, and have seen for some time, dramatic increase in the needs of patients, of residents, when they first come to long-term care. And I don't think that is going to diminish in any sense. It seems somewhat at odds with what Ms. Mersman has suggested. One of the things that I have been repeating now this year is 1964 is considered the last year of the baby boom cohort. So though the last of the baby boomers shall all turn 60 years old this calendar year. So we are not going to see a diminishment in that number. But as to the specific report, if Mr. Blackmore is not aware of it, then I think that is certainly something that we should stay on top of.
Well, thank you, Chair. I have a meeting with Ms. Mersman tomorrow. I'll certainly seek that out for you. But in terms of where we're at, where we thought we might be, I can recall we're looking at planning for the new Miramichi Lodge, and how many beds will the county need. There was a thought that County Renfrew would be at a plateau well, that never really came to fruition, or, we continue to climb in terms of the need.
Bill Gates thought we would only need 640K. Boy, was he wrong. Any further new business?
Yes, Chair.
Acting Chief, Deputy Chief Levy.
Thank you. Through you to the committee, just as a point of clarification, thanks to Mr. Burke, who brought it to my attention, just for clarification to the committee, our ERVs, which are SUVs and our pickup trucks and those sorts of things, they're on a 5-year replacement cycle. The ambulances are on a 4-year replacement cycle. So in practice, we've been able to receive the ERVs and the pickup trucks usually within a year. So we're following that one fairly closely, but the ambulances, even though they're on that 4-year replacement cycle, it's 5 and now pushing into 6 years that we're actually receiving them. So I just wanted to make sure that was clarified for the committee.
Thank you very much for that, and using the term in a different sense. So we had used it earlier. I mean, that compression is even more significant on a 4-year, given that we're now in a 2-year. So it almost seems that the day we go in to pick up the new ambulance, we should be ordering its replacement. Not far off. Thank you so much for that, Acting Deputy Chief Libby. Any further new business? I see none. Now, there is a change to the agenda for the closed meeting. There was none at the time of mailing. However, we do have a need for a closed meeting per Section 239 2D of the Municipal Act 2001 as amended to discuss labor relations or employee negotiations, and this is with respect to the paramedic negotiations. So I would seek a mover to go into closed session, please. Councillor Wilmer, seconded by Councillor Lafreniere. All in favor? That is carried. Thank you for your patience, everyone that has been watching us virtually. We are now returned to open session. And we do have a singular resolution emanating from our closed meeting. And I would prevail upon Mr. Belmore, I believe, if you would be so kind as to read the recommendation. I will seek approval and provide the background, please.
Thank you, Chair, and through you to committee. The recommendation is that the Health Committee recommend that County Council adopt a bylaw approving the new collective agreement between the Canadian Union of Public Employees, Local 4698, the County of Renfrew Paramedic Service, and the County of Renfrew for the term January 1st, 2024 to December 31st, 2026.
Thank you very much. I would seek a mover, please. Councillor Yon, seconded by Councillor Wilmer. A background, please, Mr. Belmore. What you may, what you are permitted to disclose.
Sure. So we last night tentatively concluded our rounds of negotiation pending County Council and Union ratification of the agreement.
Thank you very much. Any questions or comments, committee? I see none. All in favor? That is carried. Thank you so much. With that, that does that report doesn't need approval on its as a whole. Okay, thank you. The date of our next meeting shall be Wednesday, August 14th, 2024, and it will be at Miramichi Lodge, correct, Mr. Kelly?
That is correct, sir.
Thank you. So if you show up here and the parking lot is empty, that should remind you to go across town, right down by the river. Thank you. And I would seek a motion to adjourn, please. Councillor Wilmer, seconded by Councillor Lafreniere. All in favor? We are adjourned. Thank you.